Good evening, dear colleagues and friends. Again, it's Wednesday, and Wednesday evening is ESGE Webinar series. So I'm Konstantinos, Triantafyllou, Professor of Gastroenterology from Athens, Greece, and I'm very glad to see you all around again to attend our session. And as you may already know, this is the third consecutive year where ESGE offers you the opportunity to view the highest quality of presentation on the hottest topics regarding endoscopy, and of course from the world leaders in the field. And also you have the opportunity to interact with the speakers and to participate by submitting online questions. Of course, the activity is still free. So may I ask you to start during the presentation, submit your questions using the chat function of the Zoom. And to cut the long story short, it's my greatest pleasure to introduce Claudio de Angelis from Turin in Italy. Claudio is an exceptional endoscopist. He is the Secretary General of the European Group of Endoscopic Ultrasonography. He is a pioneer and a leader in the field, and it is honestly our greatest pleasure and honor to have him with us today to discuss the diagnostic challenges in the endoscopic ultrasonography of pancreatic cysts. Claudio, thank you for being with us, and you have the microphone.
Thank you very much, Constance, and good evening to everybody. Welcome to this EGEUS-ESGE webinar on the diagnostic challenges in EUS in the field of pancreatic cysts. These are my disclosure, and now we can go directly in medias res, speaking about the burden of disease. The prevalence of this disease ranges from 2.4 to 24%, but even until 40% in some MRI series and 50% in some autoptic series. The prevalence increases with age. All patients with a pancreatic cyst, symptomatic or asymptomatic, require a diagnostic workup because we evaluate the appropriate treatment or the appropriate surveillance for that patient. The increasing number of modern imaging modalities led us to discover an increasing number of pancreatic cysts, and these cysts always represented a complex dilemma for diagnostic imaging and for clinical management. To find the way in this labyrinth of different differential diagnoses is very difficult. And how can we find the true north? We can try to simplify the principal differential diagnosis, that is to demonstrate that the two big group of cysts that we must define are the inflammatory one, the pseudocyst, and the neoplastic one. And inside the neoplastic cyst, those with that are malignant or with a high malignant potential, and those that are benign or with a low malignant potential. It is clear that there is no one and only test, so the diagnostic approach must be a puzzle that we must solve, and one of the first piece of the puzzle can be the epidemiology. So we can take into account the sex differences. The mucinous cyst adenomas, for example, are almost exclusively found in women, and more than 90% of solid pseudopapillary neoplasm are women also. There are also site differences in the pancreas, so the mucinous cyst adenomas are almost exclusively in the body tail. The second piece of the mosaic can be the clinical context. Also, this can be a very important one. For example, if we are in the context of a von Hippel-Lindau syndrome, we have a patient with a history of acute pancreatitis or abdominal trauma, its symptoms can make all the difference. We must consider morbidities, age, and life expectancy, and mainly if there is a family history of pancreatic cancer. In this respect, just to orientate in this difficult panorama, we have a lot of guidelines from the International Consensus Fukuoka Guidelines of Tanaka 2012, Del Chiaro and others European Expert Consensus Statement 2013, our Italian Consensus Guidelines for the Diagnostic Workup and Follow-up of Cystic Pancreatic Neoplasm 2014, the AGA Guidelines in 2015, the revision of the International Consensus Fukuoka Guidelines by Tanaka 2017. And then we also have in 2017 inside the clinical guideline on EUS-FNA of our society, the ESGE, we have a chapter on the pancreatic cystic lesion. And also in the technical guideline of the ESGE in 2017, there is a chapter for pancreatic cystic lesion. Last but not least, the European Study Group on Cystic Tumors of the Pancreas revised his guidelines on pancreatic cyst on GATT in 2018. Coming back to our mosaic, our puzzle, the next puzzle, the next piece of the puzzle is due to the possibility of doing a morphological, radiological diagnosis. And if you have a look at the guideline, we can say that in asymptomatic patients and in symptomatic patients, high-resolution imaging techniques, including MRI with MRCP and or multi-detector CT with a pancreatic protocol, represent the first diagnostic step. Also, the European guidelines speak about MRI and CT, and they report the accuracy of this technique for identifying the specific type of pancreatic cyst. But for sure, what we can say is that the conventional abdominal ultrasound is not able to definitively diagnose pancreatic cyst. The multi-detector CT and MRI are the best imaging for differentiating mucinous versus non-mucinous or benign versus malignant cyst. MR with MRCP, best imaging for evaluating the communication with the main pancreatic duct. So MR with MRCP can be considered today the imaging method of choice for pancreatic cyst, and is the preferred method for follow-up of the pancreatic cyst. In face of these very good results of the radiological, morphological modalities, is there still a role for EUS in the diagnosis of pancreatic cystic lesion? EUS and EUS-FNA represent the first piece of our puzzle. And we can ask to ourselves if EUS is always necessary. If we are in front of an asymptomatic, small, less than 1 centimeter cyst, also this cyst require, as we already said before, a diagnostic workup. But if the cystic lesion has been discovered with a high resolution technique, no further investigation usually is needed at the beginning. So EUS is not necessary. Should undergo EUS instead cyst superior to 3 centimeters with thickened enhanced walls, with non-enhanced mural nodules, with the size of the virsum of 5-9 millimeters, or an abrupt change in the virsum caliber and distal atrophy, or the presence of lymphoadenopathy. So what are the indications for performing EUS in pancreatic cyst? EUS is recommended if the cyst has either clinical or radiological features of concern identified during the initial investigation or during the follow-up. EUS is helpful for identifying cysts with features that should be considered for surgical resection. When suspicious morphological features are identified or in patients with an uncertain radiological diagnosis, for example, small branch duct IPMNs versus small serous cystadenoma, EUS with FNA for cytology is recommended. EUS can have a role also in differentiating mucinous and non-mucinous cysts, and a review of 7 studies reported accuracy ranging from 50 to 90%. The inter-observer agreement between endosonographers appears to be low. EUS and MRI have similar sensitivity in identifying communication with the main pancreatic duct in the diagnosis of branch duct IPMNs. And if we want to differentiate between benign and malignant cyst, EUS can identify morphological features which increase the suspicion of malignancy in pancreatic cyst. However, morphological features identified at EUS alone cannot exclude the presence of malignancy in the cyst. EUS is more sensitive than multi-detector CT in detecting solid components in IPMNs. However, the usefulness of EUS in distinguishing mucus from mural nodules has been recently assessed with a 75% sensitivity and 83% specificity versus 24 sensitivity, 100% specificity of CT. The mural nodules are dangerous characteristics of the cyst, and this is true because in 23% of cysts with nodules, we can find cancer or high-grade dysplasia versus only 3% of cysts without nodules. But mucus account for 65% of the intracystic lesions EUS detected. And we have some echogenic characteristic, that is the echogenicity, the edge, the rim. And if all these three features are present together, the accuracy of only morphological EUS is near 90%. If we assume a 7 millimeters cutoff as for the mural nodule, we have a sensitivity of 74.3% with a specificity of more than 70% for diagnosing malignant IPMN. But new tools can give us some help as the contrast enhanced EUS that can be helpful in the differential diagnosis of pancreatic cyst and helpful in ruling out neoplastic degeneration. Also, the analysis of intracystic nodules with contrast may help in differentiating neoplastic tissue from mucus and debris. The literature on the use of contrast in the differential diagnosis of pancreatic cyst is very limited. Serous cystadenomas typically appear hyperenhanced at contrast-enhanced EUS. The signal is detected inside the septa and the cyst wall. And the intracystic nodules that are tumoral may show some degree of enhancement, unlike mucus plugs and debris, which obviously are non-enhanced. Also in the European guideline, the presence of hyperenhancement of a mural nodule, a solid mass or septation of contrast harmonic EUS raises concern for malignant transformation, and EUS fine needle aspiration of the lesion should be considered. Contrast enhanced EUS can have a very good sensitivity. We have here a video about a mural nodule in this cyst with a specificity of 80%. This is the mural nodule here. This is the image with contrast. And you can see that the contrast appears a little in the wall of the cyst, but the mural nodule here is completely non-enhanced. So we can say with a high accuracy that this mural nodule is a mucus clot and not an epithelial nodule. The positive predictive value of contrast enhanced EUS is 92%. The negative predictive value 100%, with an accuracy totally of 94%. But EUS role today is no more limited to imaging alone. We also can perform fine needle aspiration of the cyst. And when should we perform EUS FNA? Only when the results are expected to change clinical management of the patient. Only when suspicious morphological features are identified, or in patient with an uncertain radiologic diagnosis. It has small branch duct IPMNs versus small serous cystadenomas. EUS morphology alone has a modest diagnostic yield, but EUS FNA is recommended for differentiating the type of pancreatic cyst. And in this respect, we have also the ESGE recommendation for pancreatic cystic lesion. ESGE recommends US-guided sampling for biochemical analysis plus cytopathological examination if a precise diagnosis may change patient management, as we already said, except for lesion less than 10 millimeters in diameter with no high risk stigmata. If the volume of the cyst aspirate is small, it is recommended that CEA level determination be done as the first analysis. EUS FNA improves diagnostic accuracy in pancreatic cyst for differentiating mucinous versus non-mucinous and malignant versus benign in cases where CT or MRI are unclear, and a combined analysis of cyst fluid, CEA, and cytology provides the highest accuracy for differentiated. For differentiating mucinous from non-mucinous cyst. For sure, EUS FNA should not be performed if the diagnosis is already established on cross-sectional imaging or where there is a clear indication for surgery. Also, in this respect, ESGE suggests performing direct wall puncture and or KRAS mutation analysis in selected cases, for example, if the PCL aspirate is too scant for assessment of CEA concentration. ESGE did not find sufficient evidence to recommend the analysis of other biomarkers or other ancillary technique, of which we will speak afterwards. For diagnostic sampling of pancreatic cystic lesions without a solid component, ESGE suggests time the cyst with a single pass of a 22 gauge or 19 gauge needle. And then when there is a solid component, simply you must use the same technique as in the case of other solid lesion. the evaluation of cyst fluid CEA combined with cytology or KRAS GNAS mutation analysis may be considered for differentiating an IPMN or mucinous cystic neoplasia from other type of cyst. To differentiate benign cysts from those harboring high-grade dysplasia or cancer, EUS FNA may be considered, and any solid component or thickened cyst wall should be targeted for cytology. But the global accuracy of EUS FNA is in the literature around 50%. That is, don't ask too much to cytology in the cyst. If you want to differentiate between mucinous and non-mucinous cyst, EUS FNA is indicated when the other diagnostic modalities fail to give a definite differential diagnosis. And in the differentiation between serous versus IPMNs or mucinous cystadenoma, EUS FNA is the only method which can give a diagnosis with accuracy rates near 80%. The CEA levels in the cyst fluid provide the best predictor, the most valuable cutoff for serous cystadenoma diagnosis is a CEA level less than 5 nanogram per ml, while the best cutoff to differentiate a mucinous lesion is a CEA level superior to 192. And if we want to differentiate between benign and malignant cyst, again, EUS FNA is indicated when a previous diagnostic modality has depicted the cyst with worrisome features other than an enhanced solid component, when the other diagnostic modalities fail to give a definite diagnosis, or in cases of advanced malignant cyst, when chemotherapy is considered in order to have histology to send the patient to oncologic protocol. How to perform EUS FNA? On the aspirated content, we can measure the viscosity, we can have the cytology, we can measure the CEA, but as you know, the intracystic CEA is not accurate in differentiating malignant from non-malignant cyst. Also, the amylase can be used for differentiating, communicating from non-communicating cyst. Are any other tests recommended? No test other than CEAs, CA99 and amylase can be recommended. But we are here in 2014, and today we must consider some other tests, such as the intracystic glucose concentration. This is only a curiosity. We published in 2011 the possibility of make some help in diagnosis a pancreatic neuroendocrine cystic tumor, dosing the chromogranin A on the cystic fluid. But very recently, we published this study on 56 patients where intracystic glucose concentration less than 50 milligram was significantly more sensitive than a concentration of CEA superior to 192 nanogram for the diagnosis of mucinous cyst. Sorry, with a difference that is statistically significant. Regarding the diagnosis of non-mucinous cyst, the intracystic glucose concentration superior to 50 milligram showed higher sensitivity than CEA level less than 5 nanogram, although a statistical significance could not be reached. So I think that given its diagnostic performance and ease of measurement, intracystic glucose may replace CEA antigen in the differential diagnosis of mucinous versus non-mucinous pancreatic cyst. At this point, we have all the pieces of the puzzle together, and we can ask some question. can we also always answer at the question, what type of cyst is it? We can answer with all these possibilities often, but not always. Is the cyst malignant? Sometimes we can ask to this question, we can answer to this question. Can the cyst become malignant? We can answer often, but not always to this question. Up to 50% of cysts remain indeterminate even after extensive evaluation, and from 6 to 20% of pancreatic resection are performed for benign disease with no malignant potential. So we need at this point some help, and the future perspective remains on the molecular markers, KRAS, LOH, DNA quantity, VHL mutation, SMAD4, GNAS, interleukin-1 beta, plectin-1, the microRNAs, the mucin profiling, and so on. The molecular markers require less than 0.5 ml, so can be done only on small amount of cyst fluid, but there are problems relatively to costs and availability. We need standardization. We need larger and prospective studies, and at present, no molecular markers are available in clinical practice to differentiate mucinous from non-mucinous or benign versus malignant cyst. And this is the recommendation of ESGE that suggests performing direct wall puncture and or KRAS mutation analysis in selected cases. For example, if the aspirate of the cyst is to scan for assessment of the CEA concentration. Also, the European evidence-based guidelines on pancreatic cystic neoplasm claim that DNA markers in the cyst fluid, in particular mutation in GNAS and KRAS, have shown promise in identifying mucin-producing cysts. In cases in which the diagnosis remains unclear and a change in diagnosis will alter management, the search of this mutation using highly sensitive techniques such as next-generation sequencing may be considered. More perspective. It is easier for a camel to go through the eye of a needle than, for sure, we don't want to put a camel inside our FNA needle, but we can put, not in the eye, but in the channel of our needle, a microforceps. And this multi-center prospective study demonstrated that microforceps collection of tissue for histologic analysis is safe and feasible with an acquisition yield of 83.3%. The histological analysis of samples collected with through the needle microforceps identified a larger proportion of mucinous cysts compared with cytologic analysis of sample collected by FNA. The adverse event rate seems high, 12.3%, but it was mainly an intracystic, not important bleeding, 6.1%. In 6 patients, 5.3% developed post-procedural acute pancreatitis, but only one of these cases was developed a pseudocyst. This is the last work on this subject. The conclusion are that in the evaluation of pancreatic cyst, the use of a combined US-guided FNA, microforceps through the needle, and confocal laser endomicroscopy is safe. And microforceps and needle confocal laser endomicroscopy led to significant improvement in specific diagnosis of pancreatic cyst, which in turn has major impacts in clinical management. We can also perform through the needle cystoscopy using the old fiber optic of the spyglass legacy. And you can see here some result in distinguishing between mucinous versus non-mucinous cyst. And again, we have here one of our video about cystoscopy through the needle inside a mucinous cyst. You can see the clouds of fog due to the mucus inside the cyst, and also there is some vessels and a septum here that is not without vessels on the surface. And I think we must go on. Speaking about the needle-based confocal laser endomicroscopy, the result of this new technique are very good. Again, our video here. And in this short video, we can try to see the characteristic of a serous cystadenoma that sometimes are visible. You can see here. And with this characteristic, you have an accuracy superior to 90% that this cyst is really a serous cystadenoma. In the differentiation between mucinous versus non-mucinous, the INSPECT study demonstrated a sensitivity of 59% with a specificity of 100%. The DETECT study, a sensitivity of 75% versus a specificity of 100%. And in the diagnosis of serous cystadenoma, the CONTACT study is 62% sensitivity, 100% specificity, and the CONTACT-2 study 69% sensitivity, 100% specificity. This is the last systematic review and international Delphi consensus report on confocal laser endomicroscopy for evaluation of pancreatic cystic lesion. We will go rapidly through this slide just to see that some of the consensus state that needle confocal laser endomicroscopy is reliable to diagnose serous cystadenoma accurately, but they indicated that needle confocal laser endomicroscopy is indicated in patients with indeterminate non-communicating cyst when EUS-FNA is performed, or when a pancreatic cyst remains indeterminate at the previous EUS-FNA. There are some other evidence of this technique, but the conclusion are that the US guided needle CELE is a minimally invasive procedure that improves evaluation of pancreatic cyst. The routine addition of needle CLE to standard EUS-FNA could positively impact patient management and improve healthcare resource utilization, reducing the number of misdiagnoses and preventing redundant follow-up investigation and unnecessary surgery. It is needed a structured training of endosonography in this novel technology and also complementary research on cost effectiveness. And we are at the last slide, our take-home message. EUS ultrasound, CT, MRI, and EUS morphology alone may not be enough for the differential diagnosis of pancreatic cyst. EUS-FNA may be of help only in questionable cyst, combining cytology, CEA level, amylase, and glucose in the aspirated fluid, and only some DNA markers till now, such as mutation in GNAS and KRAS. The true capped biopsy of the cyst wall has been demonstrated feasible, but this needle is no more available. We must look at the role of the new Procor needle that has been demonstrated feasible on cyst wall. No, we have no data with the new Charcot needle or Acquire needle on the cyst wall. The EcoBrush, also our group demonstrated that the EcoBrush on the cyst wall is feasible, but also the EcoBrush is no more available because of the complication risk. And at the end, through the needle confocal microscopy probe cystoscopy with optical catheters and microforceps are still considered experimental and risky. But the latest data probably will change the future guidelines on this subject, and we will see that the PCLE, the needle-based confocal laser endomicroscopy with the Acuflex Mauna Kea Selvizio probes and with the microforceps will be introduced in the next guideline. So I will finish my presentation remembering to you that the prediction is very difficult, especially about the future. Thank you very much for your attention.
Thank you very much, Professor, for giving us a highlighted presentation on this very difficult problem. I mean, you tried to clarify a lot on the challenges that you face, or the average, or the expert, or even the expert gastroenterologist, the expert endoscopy faces in the differential diagnosis and in the management of cystic pancreatic neoplasm. But if I can conclude or on your presentation, the answer for the average endoscopist is that we have a long way to go more. Would you agree with me?
Yes, absolutely, I agree.
We are very happy that we have more than 360 participants at this, and we thank our participants for supporting this activity. And as you can understand, if we have so many participants, we have many answers. So we go through the answers of our attendees, and for the majority of them are a little bit more technical, but they also have questions facing the subject of this webinar. One of the question is, as an expert, which is the best patient with a cystic pancreatic neoplasm to be evaluated with endoscopic ultrasound? So you saw that there are many cystic neoplasms. You saw that we have epidemiological and other tools in our armamentarium. But you, as an expert, if you would choose one subject with pancreatic cystic neoplasm to be evaluated by yourself with the endoscopic ultrasound, which patient would be that?
For sure, must be a patient with a cyst that is not clearly defined by the CT scan or the MRI, or a patient that during the follow-up demonstrates some changes in the morphological features of the cyst. In this case, for sure, EUS is indicated. To tell you the truth, when we face a patient with a pancreatic cyst, in the workup of the patient, at the beginning of the workup, we use to put the patient under EUS evaluation, even for cyst that seems to be quite simple or not too big, in order to have a very exactly quantification of the risk of the patient, and to establish rightly the follow-up of the patient.
Okay, thank you. And let's move to some of the technical questions. So if the patient is taking aspirin or antiplatelets or anticoagulation, would you recommend stopping them before the examination? For how long, and when to resume this medication?
Yes, the puncture of a pancreatic cyst is the only case in which we ask to the patient to stop for at least 7 days before the aspirin, and they can reassume the aspirin the evening after the procedure.
And is it the same recommendation for the anticoagulation? I mean, warfarin and the drugs, or?
Yes, for the anticoagulation, the recommendation is that we must have the PT in order under 1.4 when we perform the EUS-FNA.
Okay, and now if you allow me, let's go to a case scenario sent by one of our attendees. So in their department, they had a 50-year-old man with a history of chronic pancreatitis. And in a follow-up examination, they performed an MRI and they found a 5-centimeter cyst in the body of the pancreas. They performed EUS-FNA because the patient was in pain, and they found CEA 500 nanograms and amylase 1000 in the cystic aspiration. So what would you recommend to do next?
So this is a cyst of 5 centimeters, and the CEA level was
500.
500.
And full of amylase also.
And full of amylase.
Chronic pancreatitis patient.
The possibility, this is based on the cyst fluid analysis, this should be an IPMN, because there is a high level of amylase that means communication with the duct, and the high level of CEA is in favor of a mucinous cyst. The possibility of having chronic pancreatitis with IPMNs is well known, and IPMN and chronic pancreatitis are together in 30% of cases in the same patients. So I think that with a cyst of size 5 centimeters, we should carefully follow up the patient. If the patient is symptomatic, as in this case, the patient could be symptomatic for the chronic pancreatitis, but also for the cyst, we must consider the possibility of surgery.
It's a difficult case. It's a difficult case. And of course, other epidemiological factors may change our attitude towards the patient. So if it is unfit for surgery, of course.
Yes, of course.
Then we change. But it's a 50-year-old man, so it's difficult to decide. Now, if you allow, we have 2 nice questions about the role of elastography. First of all, regarding the verification of the mural nodule, and regarding the verification of the fluid. So is there any place for elastography for these 2 verifications?
In my mind, elastography for the fluid density is absolutely useless. And it can be used if you have a solid tissue or a mural nodule of some entity. And in that case, you can use elastography, but I don't think that it is it can be very useful for the differential diagnosis, because if you have a mural nodule that is demonstrated to be tissue, you should puncture the nodule. And so EUS elastography can be a curiosity, but not a necessity.
Okay. And then we have a couple of questions that are taking us to hopefully the near future. They are about the indication and the value of 3D EUS, and especially in detecting the disruption of the pancreatic duct. So the scenario is you have a patient with, in the setting of acute pancreatitis, he has a pseudocyst, and she has also ascites, pancreatic ascites. And it is very difficult to find out with other modalities if there is a disruption of the pancreatic duct. Our colleague requests to have some more information about the 3D endoscopic ultrasound. What is your opinion, and what is the evidence behind that?
But I'm not an expert in 3D endoscopic ultrasound. We use 3D EUS with mini probes, also in the biliary tract and in the Wirsung duct. But about three-dimensional reconstruction of standard EUS, it is possible, but as far as I know, it has not been very well developed in the last years. The possibility of having very good 3D reconstruction with the novel echographic machine is well known. But I think that till today, the best imaging modalities in this clinical scenario is MRI, with all the possibility of reconstructing the images of the MRI.
Okay, now we have two questions regarding the value of glucose measurement. And one question is if the results of your studies have been replicated by other groups, and what would you recommend as a marker, the glucose below 50 or CA below 192, or both? Your expertise is required here.
There are, our study is the last published this year, and there are other 4 studies that plus or minus tell the same thing. So there are till now 5 studies about the glucose level using the cutoff of 50 milligram per ml in the fluid of the pancreatic cysts. And today, I think that we can use both because the cost of the glucose dosing is not so high. But if we have to choose today, I think that the data are enough good to tell that the glucose level is the best test with respect to the CEA level.
Okay. And now we come to a relative common condition. So we have a patient with main duct IPMN. So is there an indication, or which is the indication in this patient to undergo endoscopic ultrasound? Or otherwise, all main branch IPMN should be examined with endoscopic ultrasound and fine needle aspiration?
I think that in main duct IPMN, FNA is not so helpful if you don't have very important intra-Wirsung duct nodule or solid masses. Mm-hmm. But EUS can be useful in well delineating the main duct IPMN, in having a look at the papilla and the sign of the fisheye. That could be useful to have a rapid endoscopic diagnosis, and it can be present in 40% of cases. So it is very difficult to send the patient directly to the surgeon only based on the CT scan or MRI data that we can have. And I think that in this case is an EUS with FNA only if a solid mass can be depicted, must be always done before surgery.
Another technical question is about the administration of prophylactic antibiotic therapy in patients which are candidates to undergo FNA, endoscopic ultrasound FNA.
Working for some of these guidelines that I mentioned to you during my presentation, we found that there is no evidence, scientific evidence, that antibiotics are clearly useful for in prophylaxis. But I think that all the world and ourselves even are using antibiotic prophylaxis based on nothing scientific evidence.
So, and another technical question is about the size of the needle. Is there any role of a smaller needle, 25 gauge needle for cystic fluid aspiration?
No, for sure not, because if you go down to 22 gauge needle level, you are at high risk of not being able to aspirate nothing from the cyst if the viscosity of the fluid is too high. So I think that if possible today, you must puncture a pancreatic cyst with a 19 gauge needle.
Again, technical questions. You have a cystic neoplasm and there is fluid in there. You do perform the FNA. Would you try to completely empty them? Is there a danger for intracystic bleeding if you completely empty them? Or on the other hand, is there a danger for an infection of the cyst if you leave some of the fluid inside?
The best recommendation in this case is if it is possible to try to completely empty the cyst after the puncture. This is the best way to act till now, and it is based, I think, on expert consensus and not on scientific basis, but I think that the recommendation is to empty completely the cyst.
And another question is about it's therapeutic, it's about the ablation of cystic neoplasms, malignant cystic neoplasms, if the patient is not a good candidate for surgery.
Yes, this is today a possibility. We can use the injection of alcohol or paclitaxel into the cyst, but we can also use radiofrequency ablation after aspiration of the major part of the content of the cyst. It is possible if there are no place for surgery.
And what about the complications of the endoscopic ultrasounds? Are there, and FNA, of course, are they fearable? What is the rate of, let's say, the intracystic bleeding? And how would you treat a bleeding like that if it occurs?
In a normal FNA, the intracystic bleeding can occur, but at a rate less than 1%. And the most important complication that can go up to 2.2% is pancreatitis. And if you use a lot of ancillary techniques such as a big needle, 19 gauge needle, and through the needle, you go inside the cyst with a fiber scope or with a microforceps or with a Salvizio probe, Acuflex probe. So the possibility of intracystic bleeding can go up to 6%, but always in all cases, the intracystic bleeding is a spontaneously stopping bleeding. And it is not a real complication. You don't need treatment for that kind of intracystic bleeding in the vast majority of cases. The problem of pancreatitis is a bigger problem. And if you have technique, you can go from 2.2% of pancreatitis until 5% of pancreatitis using a lot of intracystic through the needle procedures. And we must pay attention on this data.
Okay, probably this is the last question. You clearly indicated that we hope a lot from novelties in the field of EUS ultrasound. In your opinion, as an expert, what is the near future? I mean, which is the modality that you expect that will be available and change the practice in the management of the diagnostic challenges of pancreatic cystic neoplasms?
I think for sure that the new data that we have, and I try to demonstrate during my presentation, that will change our approach to pancreatic cyst and will help us in order to give a differential diagnosis that remains difficult in about 50% of cases, is the possibility of using an ancillary technique through the needle, such as the microforceps and the confocal laser endomicroscopy that can be used more widely, I hope. We are using this technique from many years now, but they are not so widely diffused. And for sure, we must go on with the biomarkers to be those in the cystic fluid. But we must have some more standardization. There must be cost more or less than that are today for example, genome sequencing that are cost very, very high. So these are the possibility that I see in this field for EUS and the diagnosis of pancreatic cyst in the near future.
Thank you very much, Professor Angelis. It was a great pleasure. And as the time goes by, I feel very good because during this session, we had the opportunity not only to adore your presentation, but also to provide answers to the majority of the questions sent by our attendees. It was a nice webinar, and this is time, before saying goodbye, that I have to remind to our attendees that the recording of this webinar will be posted on the e-learning section of the EGEUS site. At the same place, everyone can find previous webinar, and you can check it out whenever you want. So they're still there for you. And to have this webinar, we have to give some thanks to the governing board of the society because they give us the opportunity, and to our technical team, Tev Inger and Gabriela Varga, for hosting us and making everything easy for us. And of course, next week we have another satellite webinar, and a webinar sponsored by Olympus and Advances in Small Bowel Therapy. So remember, Wednesday webinars. Every Wednesday evening we have a webinar, and we have also, beyond the webinars, we have new benefits for our ESGE members. We have my tutor, my ESGE tutor. It's an excellent tool with many modules now to test and to verify your knowledge in specific fields of endoscopy. And the new kid on the block is the ESGE quality check application. So if you would like to measure your quality of endoscopy in your department and you don't have an automated system, this application will provide you the opportunity to do that in colonoscopy and upper GI endoscopy. And of course, this is a reminding that until the end of the month, we can accept submission of your abstracts for the ESGE Days 2021, which again will go virtual because time is difficult and no one could secure an event as we knew it in the past. So thank you, Professor De Angelis. Thank you, Gabriela and Dave. Thank the attendees for being with us. It was an excellent webinar, and until our next webinar, au revoir.
Au revoir. Au revoir. Thank you, Gabriela, David, and Constance.
Bye-bye.
Thank you to you. Bye-bye.